it's based off their genotype and their environment, right? All right, so you got a newborn infant. They have a left heart ventricle that's smaller than normal. What type of morphogenic area do you think this represents? So we got Charlie, we got Delta. So it's smaller than normal. It's still there. They still have one. It's just smaller. What's that? Potentially. There's four things, right? But there's something called left hypoplastic heart syndrome. Pediatrics will get into that with you. But this is what this is trying to say. We didn't talk about that, but it's more so just to let you see how that's a form of hypoplasia. Right? They still have the tissue there. It's not just like little tissue or non-functional tissue. The actual left ventricle is there, it's just smaller. All right, so you got a couple coming in. They want some genetic counseling. Husband and wife, they're heterozygous, right? They're heterozygous for sickle cell genes, so they have one normal copy and one abnormal copy. Based off that, what percentage of their children will potentially have the full sickle cell disease? So both abnormal copies. So that's where you kind of square and you kind of write that out. 25? I like 25? I like that too. Yeah, so again, if they're heterozygous, right? This is a recessive trait. When that child starts to inherit those genes, when it breaks down, 25% of those children are going to have that normal copy, and they're going to have both of them, so they're going to actually display that. It's a recessive trait. The rest of them are going to have the trait. They're not necessarily going to have full sickle cell disease, but potentially one of those children are going to have that disease. All right, so which of the following is a monosomy chromosomal error? Turner's? Down syndrome? Turner's? Yeah, so remember Turner's, they just have that X chromosome. They don't have another chromosome. That 0 is just a placeholder. It doesn't mean that they have a chromosome there. But they just have, Tina Turner tiny? Tina Turner is tiny. Okay, one. Yeah, I like that. Yeah, so that helps you. Yeah, Turner syndrome just has that one. Now, what's that?
It's Tina Turner. Because it's female only. Tina Turner, female only.
Cool.
How do you know that? They know that, right?
Just know it.
So somebody asked me yesterday, and I want to make it clear, there's no Y version of this, right? There's no 45Y0, because if you have that, that's not compatible with life. You need that X. That X is necessary, so there's no male version of this. Make sense? So you got a male with X-linked recessive disorder, and they would pass along this disorder in which type of pattern? You got to assume that the female partner has normal genes. D? So it's probably not going to be E, right? We talked about this yesterday. Yeah, so if the male has that disorder, he can't pass the X chromosome to his son, so son's not going to have this, but he can pass it along to his daughter. And if the daughter has this, typically, most likely, they're going to have just a trait because they get that normal copy from their mom. That's typically what happens. It's very rare that an actual daughter actually has the disease. They have to get one abnormal copy from the mom and the dad. That doesn't happen too often, based off the types of disorders that these people have. Most of the time, they know the brain, unless you have hemophilia A, then maybe you won't know. Most of the time they know though, so it's not very common that women are going to have this. They'll have the trait for sure, but they're not going to have the disorder most of the time. All right, what is the most common lethal autosomal recessive disorder amongst Caucasians? I heard some stuff. Yeah. Cystic fibrosis, remember we talked about those Northern Europeans, they are most commonly affected by this, so This is one of those typical board parents questions that they like to ask about cystic fibrosis. Most of the time, you're not going to see this, especially if you're in active duty medicine, but potentially if you're out working in the civilian sector, you could run across this. So good job, guys. All right. So today we're going to be talking about fluids, right? We're going to talk about fluids. We're going to talk about edema and swelling, and where you can see that edema and swelling. We're going to talk about what makes up the edema. So if you have a patient who has edema, they have swelling, if you were to analyze that fluid, what is it going to be primarily made out of? We're going to talk about how blood clots form and some certain risk factors for developing blood clots. And we're not talking about so much injury related, right? We're talking about those blood clots you can get in your lungs and your legs. Those are the ones you don't want, obviously, very serious if the patient has that. We'll talk about hemorrhage just a little bit, just kind of go over some definitions, and then we're going to talk about shock. So just some basic terminology. So the main thing I want to point out here is that you got these two words up at the very top. You got intra and inter. So intra just means inside, right? So intracellular, we're talking about inside of the cell. Inter means that it's in between. So they kind of sound similar, and sometimes people get this mixed up in their head. But inter just means it's between things. So typically when we're talking about inter, we're talking about interstitial. And we're talking about that space between the cells. So it's not inside of the cell, it's outside of the cell, but it sounds very similar to intra. So just make sure you understand that. Intra, inside, inter, outside, but we're talking about a space in between. Most of you probably already know vascular. When we're talking about vascular, that refers to blood vessels, and you can have intravascular. So when you're giving IV fluids, you're giving fluids inside of the vein, right? Versus extravascular, outside the blood vessel. When we talk about vaso and angio, these are just generic terms for blood vessels. So you'll see them kind of intermixed when people are talking about whether we're doing some type of, like angiogram is the type of imaging that you can get on a blood vessel. Phlebo or phlebe, we're talking about veins. So phlebotomy, right? If you're taking somebody's blood, and obviously we know that we're taking blood out of the vein. And then lumen, I talked about that previously. So lumen is just the inside of a tubular structure. So we have the lumen in our esophagus, we have a lumen in our colon, right? So it's just the inside of a tubular structure. So when we talk about body fluids, right? So typically a patient or you or anybody, we should be having at least 2 to 3 liters of water a day. That's the recommended intake of water. Now most people don't get that much, but whenever your patients come and talk to you and they're coming in because they're lightheaded or they're having palpitations, one of the things you want to ask them is how much water are you drinking? And if they're saying 2 to 3 liters of water a day, well then they're hitting that maximum goal, right? Or the recommended goal. Most of that is obviously going to come from our fluids. We're going to be drinking most of this, but we're going to get some of it from our foods. And then the output, right? How much we are actually getting out of our body, most of that's coming through our urine. And we need a certain amount of fluid intake in order for us to actually get rid of the waste products that our blood makes, that our body makes. And look at that. So we need at least 500 to 800 mLs a day of just fluid to help push out that waste product, that waste. We also lose fluids from other things. Obviously, if you're sweating or if you're breathing, you're going to lose fluids that way. And then if you're having, when you're passing your bowel movements, you're going to lose fluids that way, especially if you're having lots of diarrhea, where then you really worry about an extreme loss of fluids if you're losing so much fluid in your stool, right? But if you've ever worked in like an inpatient ward, right, sometimes what we'll do is we'll monitor our patients, and it's called the ins and outs. So we want to know how much fluid they're taking in and how much fluid they are releasing, right? Because if they are releasing too much fluid based off how much you're taking in, that can mean certain things. Maybe if they're a diabetic patient, maybe the diabetes is not controlled, and so that sugar is causing that osmotic effect and pulling out that urine. So okay, what do we need to do in that case? Or if they're taking in the right amount of fluid, but they're not pushing it out, they're not excreting it, then what does that mean? Are their kidneys failing? Are their kidneys not able to concentrate that and actually get that urine out of there? So sometimes, especially if that patient's super sick, then they're going to be monitoring those ins and outs, and it just gives you some important information, important details of your patient. based off how they're doing and why they're in the hospital. So when we talk about where that fluid is located, so if you see there, 60% of our body weight is fluid, right? We're mostly made of fluid. More than half of us were made of fluid, right? But that fluid's location, now, it can be intracellular and it can be extracellular. So look at that intracellular volume. 40% of our fluid is going to be inside of the cells. And that makes sense because we have trillions and trillions of cells. We have so many cells. And if you add them all up, they all have a cytoplasm, and that cytoplasm all has fluid in it. So most of that fluid is going to be inside of the cell. Now the extracellular component of it, so it's going to be in our plasma, it's going to be in our blood. That makes sense. When we draw our blood, doesn't come out as thick and clotty, it comes out as fluid, right, liquid. And that's 5%. 15% of that's going to be in our interstitial space. So that's that space outside of the cell, right? It's going to be in between those cells. And that's normal. We have fluid in our interstitial space. It's supposed to be there. But sometimes what can happen is when you have some type of inflammatory process, or you have some type of swelling, that space can actually hold on to more fluid. So whenever you actually see swelling, it's that fluid that's in that interstitial space, and that's what you're observing. So that space can hold a large amount of fluid, and if that fluid is not where it's supposed to be, if it's not in our blood, for example, then it's not contributing to our blood flow, and that can cause problems later on down the line. And that picture up top just kind of shows you that interstitial space. Again, it's just a little space that can potentially hold fluid. So lab's going to get into a lot with you about what the blood is made of, the electrolytes, right? And I don't want you to spend too much time trying to memorize like the sodium is 142, potassium is 4. Don't memorize that, right? I just want you to kind of get the big picture here. So if we were to look at our extracellular space, there's going to be more sodium on the outside, right, in that space versus potassium, because we talked about the sodium-potassium pump, right? That pump, its job is to help push out sodium and keep potassium in it. So when we're looking outside of the cell, it makes sense that we're going to have more sodium in there versus potassium. Now, if you were to go to the intracellular fluid, if you were to somehow get a sample of that, you're going to notice that there's more potassium in there than sodium because, again, those sodium-potassium pumps are working, they're doing their job. That's what it's supposed to look like. Now, if for some reason you were to get a sample of blood and you saw that there was a high amount of potassium in the plasma, what would that tell you? What do you think could be the cause of that? Acidosis. Okay, what's something more simple than that?
Hyperkalemic.
What's that?
Hyperkalemic.
Hyperkalemic? Okay. A lot more simpler than that. Good answers, but. Any lab techs? Any prior lab techs? No? All right. What? Did you read there? Yeah, okay, cellular damage. So sometimes when you draw blood, sometimes you can have a traumatic vena puncture, right? And sometimes those red blood cells can lyse. And if those red blood cells lyse, then you're going to have an increased amount of potassium in that plasma. And I bring that up because if you are ever in clinic and you get a phone call from the lab and they say, hey, your patient you just saw, they have a very extreme, worrisome amount of potassium in their blood, do not call that patient and say go to the ER right away. Make sure that the sample's not hemolyzed. I'm not going to say it didn't happen to me, but you are going to potentially scare that patient and they're going to go to the ER and then they're going to get their blood drawn again and you're going to like it. So make sure that the sample's not hemolyzed. Most of the time the lab's going to tell you it's hemolyzed. In this case, I think I asked, but I don't know how. So anyways, that those red blood cells can lyse and sometimes cause a false elevation in that potassium level. That's more common than, it's the most common thing you're going to see. All right, we're talking about actual edema fluid. So what causes swelling, what causes edema? Well, essentially it's that fluid that's escaping the blood vessels, right? And so it escapes to that interstitial space, or it can go into our body cavities, so our chest or abdomen. And when that happens, we call that third spacing. That's that third space that normally we have fluid in, we don't have a lot of it. But when we have an extreme amount of it where it's observable, then we call that third spacing. So you may hear that if you're in phase 2 and maybe you're working in a patient somewhere. If you have a patient who's super sick and maybe you hear that word third spacing, that's what they're talking about. Now, this can be caused by several things, right? So the first one, if we have an increase in our hydrostatic pressure, in our vascular pressure, and typically, so normally, you think about a tube, and if you have fluid in there, it's going to push on that tube, right? If we increase that fluid, if we increase the amount of fluid in there, we're going to increase that pressure. And if we increase that pressure, then it's going to cause it to push out more and cause that fluid to actually escape. Because our blood vessels, even though we think of them as like solid tubes, they have little holes in them, right? They have those endothelial gaps. And if you increase that pressure, you can push out more fluid because of that pressure. Now, most of the time, this is going to occur due to some type of blockage, right? So, or it's going to occur if our body's holding on to more water. And I'll show you. Typically, like we think congestive heart failure, and I'll explain that to you here in a few slides. But if we increase the pressure, then we're going to potentially increase the fluid that's being pushed out of our blood vessels. If we increase our vascular permeability, so I talked about inflammation already, right? I told you histamine comes and it causes those endothelial cells to kind of open up wider, and so that makes sense. If we open up those endothelial gaps, then we can create that space for fluid to actually escape. But when we do that, depending on how much those gaps open, kind of depends on what else escapes. So if they open up quite a bit, if they open up pretty large, then not only is fluid escaping, but you're getting white blood cells, you're getting proteins, sometimes you're getting actual red blood cells. So it all depends based off how permeable they are. So most of the time, so remember I told you guys a while back, there's different types of inflammation. We got serous inflammation, we got fibrous inflammation. So it depends on the level of inflammation that's occurring that's going to determine how much stuff is actually escaping that vascular, the blood vessel. And then oncotic pressure, so in our blood we have protein, right? And one of the main proteins that we have is called albumin. And albumin does a number of things. It does a number of things, like it helps transport different hormones, different molecules around the body that need that transport of albumin to actually get to where it needs to go. But the main thing albumin does is that it does something called oncotic pressure, meaning when you have protein in the blood vessels, it actually can help hold on to water. So we want albumin there because if we don't have that oncotic pressure, we don't have those proteins in our blood vessels, then we don't have that force holding on to water, and as a result, the fluid that we have in our blood vessels, it's going to escape. So we definitely need albumin in our blood because if we don't have that, it's going to cause a lot of issues. And the last thing is lymphatic drainage. So I told you guys a while back that we have lymphatic vessels and they go to our lymph nodes, and their job is to help collect any type of extra fluid that normally builds up in our tissues, take it through the lymphatic vessels to our lymph nodes, and then eventually get it back to our blood circulation through our vena cava. Now, if you have some type of blockage in the vessels, right? Maybe there's a tumor somewhere and it's blocking the vessels. Well, then the fluid can't get to where it needs to get to, so it's going to start backing up into our tissues. I also told you about our patients who have cancer, right? Breast cancer. And sometimes we're going to do that sentinel lymph node biopsy, and if it's positive, we're going to take out more lymph nodes. And if we take those lymph nodes out, if we strip those lymph nodes, we just can't just get one lymph node. We're going to get multiple of them, and then we're going to damage their lymphatic vessels. So when that happens, I gave you that story of that person who, if we take out those axillary lymph nodes, then they're going to have that buildup of fluid in their arm, right? Because we don't have those vessels anymore draining that tissue, and so they're going to get this increased amount of fluid inside of their actual tissue. So remember that. Okay, so when we talk about the location of edema, so typically we're talking about either it's localized or it's generalized. If it's localized, typically the way we annotate that is we say whatever organ, whatever tissue, whatever is involved, and then we just say edema. So for example, if we have edema in the foot, we call that pedal edema because the foot's swollen, it's full of fluid, it's just the foot, so then we say pedal edema. It's pretty easy, right? If it's in the brain, cerebral edema. If it's in the lungs, pulmonary edema. So pretty simple kind of way we classify this or name it. If we have fluid in a cavity, then it changes a little bit. We say hydro and then the location. So if it's in the abdomen, we say hydroperitoneum. If because we got the peritoneal cavity in there, we got fluid in there, so we just say hydroperitoneum. If it's around the heart, it's hydropericardium. But it's never that simple, right? There's always different medical terms out there. It's never just kind of black and white. So some conditions, we actually have different ways we name this. And so you'll probably see this more often. For example, hydroperitoneum, we don't really use that term. You may see it in a report here and there, but oftentimes we'll just say they have ascites. So that's one way to describe fluid in the abdomen, is that we say ascites. Or if it's around the heart, right, we say pericardial effusion. We don't typically use hydropericardium. Now, you might see it, but there's just different names for this, so I want to make sure you guys understand that and kind of point that out to you. Now, when you have kind of this widespread edema, right, when it's throughout the body, we call it anasarca. And you're not really going to see that often unless the patient is very sick. So I told you guys that albumin helps, it has that unclotted pressure, it helps hold on to fluids. Well, if somebody has some type of liver disease, and that's where albumin is made in the liver, then they're not going to produce albumin. And so if they have some type of cirrhosis, liver cancer, it's going to damage their liver, it's going to damage the liver's ability to make albumin. And so they're not going to have a lot of albumin in their blood, and so they can develop this kind of generalized edema, this anasarca. If they have kidney problems, if their kidneys are damaged, if they're in end-stage renal disease and their kidneys can no longer help or adequately filter out the blood, it's going to start letting big things pass through. One of those big things is albumin. So if they are very sick, they have bad kidney disease, then they can also develop this. And it's typically very late stage, no treatment, because typically we're going to put these patients on dialysis, but potentially, right? So that's probably what you're going to see in the States. Now, if you go elsewhere, you go somewhere where there's famine or there's not adequate nutrition, then most of the time this is from poor dietary intake. There's not enough food for these individuals to help that liver make protein, or they're not intaking enough protein. So that's what's going on with this guy here at the very bottom. Look at his face. He's got facial edema, he's got periorbital edema around his eyes, his arms are swollen, his abdomen is full and distended, probably from ascites. So that's more so, other countries that have these, that have severe, or they're going through something severe. But in the States, most likely it's going to be from some type of, liver or kidney issue. Yeah.
Sir, first basic, what's the difference between generalized
Lymphedema? Lymphedema is localized, right? Now, so generalized is going to be full body. Lymphedema, so that what I just talked about with the arm, that's an example of lymphedema. Or what's that parasite? You guys learned about it last semester. Yeah. It can, I know, right? The one I call this lymphedema, yeah, elephantitis, right? So that's the form of lymphedema as well.
Witchcraft. Witchcraft.
Yeah. So does that make sense? Hopefully you never see that. I don't know.
If it works, it works.
Witchcraft, bring back. If it works, clear? Okay. All right, so kind of going back to tissues, right? So now you're taking radiology right now. I'm not going to throw up a chest x-ray and say, what's going on here? I may, if I do include imaging, the actual vignette, the actual question should hopefully paint that picture. And then that imaging, if there is imaging, I don't know if there's imaging because I haven't looked at it, but I'm going to. If there is imaging, it's going to be more just to kind of essentially help you as long as you are aware of that, right? But you don't necessarily need the imaging for certain things on these tests. So that's what pulmonology is for, or not pulmonology, that's what radiology is for. That's where you got to know your imaging stuff. Here, it's not radiology, okay? But what I want to show you is that if you have a patient who has edema, you can actually do imaging. You can work it up and try to figure out where the issue is developing. So if we look at this bottom one down here, this chest X-ray, you can see that normally, you have a black space, that's typically air, obviously, and then you got these kind of white patterns, these white patches in there. That's fluid buildup. That's that pulmonary edema, and it's on both sides typically. If you look at the brain, you can see over here, you got the ventricles here, you can see that's normal. You can see the sulci, and then over here, it's just gray. It's just fully gray. That's what edema looks like in the brain. And you got this girl up here, around her eyes, she's got swelling around her eyes. So peri means around, right? And then orbital refers to the eyes. So she has periorbital edema. So again, we name it based off the organ. So if it's around the eyes, periorbital edema. If it's the lungs, pulmonary edema. So makes sense now. What you can also do is think about it. So if the fluid, if the edema is in the tissue, are you going to be able to stick a needle in that tissue and pull off fluid? That tissue is, even though there's space there, it's not a big space. So if you stick a needle in there, do you think something's going to come out of there? Do you think fluid's going to come out of there? No, it's not. There's not going to be any, if you stick a needle in something that's in tissue, unless it's like an abscess, which is not, it's not an abscess, nothing's going to come out of there. You're going to stick that needle in there and then it's just going to be dry. Okay? The fluid is still there. It's in that space, but that space is so small that you're not going to be able to actually get a needle in there to actually pull it out. So if you ever think, and this may help you, right? If it's in the tissue, just think, can I get fluid out of there? If not, then it's probably interstitial edema. It's in the tissue, and then we're not going to get fluid out of it. Now, for the edema in the body cavities, right? So we can get edema in all types of body cavities, but more commonly, you're going to see them in the abdomen, right? That's that size I talked about. You can get it in that pleural space, so between our lungs, that space that's normally there, that normally has a little bit of fluid. Sometimes we can get these abnormalities that cause that fluid to actually build up. Or, like I said, you can get it around the heart. Now, if it's in the abdomen, that's why we do that's why we do percussion in physical exam, right? Where even though our patients are normal here, that's what you'd be looking for, essentially, is you're looking to see if there's any dullness to percussion. If there is, maybe there's something under there that's causing that dullness, which is typically fluid. It could be other things, but typically fluid. But with ascites, if you shift that patient, if you have them lay flat, and you do your physical exam and you hear dullness, and then you flip to the side, that fluid's going to move, right, with gravity, and so that percussion is going to change on you. The pleural effusion, again, it's in that pleural space. It's outside the lung tissue, though. It's not inside the tissue. It's in that space. And then the pericardial effusion, that's in that pericardial sac, right? That's outside of the heart, so it's not in the heart tissue. It's around that pericardial sac, between those two spaces. And think about that. So if you're outside of tissue, and you stick a needle in one of these, are you going to get fluid out of that? Yes, you will. And that's how we treat some of these things. So if it's outside of the tissue, if it's in an actual body cavity, then you can apply that needle test and you can get fluid out of there. Okay? All right, so again, some more imaging just to kind of show you how you can sometimes pick up edema on imaging. So if you look down here, you got this child, and look at their abdomen. It's distended. If you look at their organs, it looks like they're kind of floating. They're just kind of right there in the center. And you see all that white, right? That's fluid that's pushing out on the abdomen and causing that distension. And if you go over here and you look at the CT, this is kind of, so just to kind of orient you, so this, can you see this? No? Yeah. Can y'all see this?
Yep.
Okay. So you got the kidneys here, right? You got the vertebrae. You got your back muscles back here. You got your liver over here, but you can't see the liver because you got all this fluid here. You can see the tip of the liver, but all this going around here, all this dark gray, that's fluid. Versus up here, same kind of view, but you can actually see more of the liver. Over here, this is what normal looks like, right? You can see the liver over here. You can see all this bowel over here. It's full of air or has some air in it. So again, if you suspect edema in somebody, you can get imaging on that patient and potentially see how bad it is. All right. So another way just to look at edema. So talking about the lungs here. So normal lung up here, right, nice and yellow. If we have pulmonary edema, that fluid is inside of the lung tissue. It's inside the alveoli and it's around the interstitial space of that lung. So this is supposed to represent that. This is pulmonary edema. Versus pleural effusion, so that fluid in that pleural sac of the lung is outside. So if you were to try to draw fluid from here, it's going to be very difficult because it's all in the tissue. Versus on the outside, if it's in the pleural space, very easily you can draw fluid off of that. And then again, another picture, now looking at a chest x-ray. So pulmonary edema, right? We got those white spaces inside of our lungs, they're on both sides. That's what pulmonary edema looks like in somebody if you were to get a chest x-ray on them. Versus the pleural effusion, now all this right here, this is all fluid. And that fluid is pushing up on that lung and kind of compressing it, right? So that's why it looks the way it does. But all this right here is fluid. This is normal, no issues here, but this person has fluid outside of the lung. Now there's something else that you're gonna run into whenever you order a chest x-ray on a patient. These are called infiltrates. And most of the time, if you get a report back and the radiologist notes that you have pulmonary infiltrates, that typically means you're dealing with an infectious process. And the difference between the two is that you still have fluid in the tissue, you still have fluid in the alveoli, but it's due to inflammation, a lot of inflammation. And typically it only affects a certain lobe of the lung. It's not going to go, most of the time it's not going to go to both sides. It's just going to be one lobe of the lung. So sometimes radiologists will say, hey, they're not going to say pulmonary edema. They might, but most of the time they're going to say that this patient has pulmonary infiltrates. And that should kind of key you in that maybe it's just potentially an infectious process. Now, it doesn't necessarily mean it's infectious, but most of the time that's what that means, okay? All right, so when we talk about fluid, right, we talk about kind of where it's at, how it starts. You can sometimes get a sample of fluid, especially the effusions. You can get a sample of it, right? And you can send it to the lab and have them analyze it. And when they analyze it, that's going to give you more characteristics. It's going to tell you what's going on with that patient based off what they find on that lab sample. Now there's two words here, right? Transudate and exudate. Transudate means that that fluid has low cellular content, it has low protein because there's not that significant inflammatory process. So we're still releasing fluid, but we're not opening up those gaps completely or all the way to allow those big things to actually escape. And the same things that cause edema can cause this. So if we're to take a sample of it, send it to the lab, there's something called specific gravity. Have you guys heard of that term before? Right? So if we do that test and it's close to water, then we're going to have a low specific gravity. Okay? Now exudate, this is typically caused by severe inflammation or a large amount of inflammation, typically from infections. When that happens, those endothelial gaps are going to open up. And when they open up, they're going to release their contents. They're going to release those white blood cells, they're going to release proteins, any type of cellular debris that came up from the white blood cells trying to fight off whatever's going on there. And when that happens, they're going to have a high specific gravity because there's a lot of stuff in there, right? So think about exudate as having extra stuff in it. It has more than transudate. And it's typically, like I said, due to some type of infectious or inflammatory process. Now, edema, infiltrates, effusions, they can either be transudate or exudate, right? So that's why sometimes you can get that sample to help you delineate that. Cool? So just another picture of what transudate looks like versus exudate. So transudate up here, clear, right? It has a little bit of a color to it, okay, cool, but you can see through it. So it doesn't have much stuff in there. Versus exudate, it has proteins, it has white blood cells, so it's going to be a lot cloudier. It's going to look like pus kind of. So it has extra stuff in it. So just some examples here. So let's look at this guy's arm right here. So I don't know what's causing this. We don't know what's causing this edema, but obviously, if you look at this arm versus the other arm, it's swollen, it's red, so it doesn't look normal. Maybe he has some type of blockage up here somewhere in the axilla that's causing that pressure to increase in those vessels and pushing out fluid. He could have some type of, maybe he rubbed some type of lotion on his arm or something, right, that causes massive inflammation that caused just that arm to swell. Or maybe he doesn't have any lymph node. Maybe he has some type of surgery maybe he has some type of cancer that went to those lymph nodes and he had to get those removed, right? So he has that blockage. Same thing down here. You can kind of follow that same path. But if he had something wrong with his albumin, do you think he would just have one arm that's swollen? He didn't have enough albumin in his blood. No, it's going to typically be bilateral. It's typically going to be the entire body. So coming over here, we can't see this person's top half, right? But if we look at both of those lower legs, well, they're both swollen. Now, it could still be any one of the other ones, for sure. But when you think about oncotic issues, it's not just going to be one extremity. It's not going to be localized. It's going to be either both extremities or typically the entire body, depending on the severity. And then there's ways of grading edema, and we call this pitting edema. So if you've ever had a patient, if you've ever seen patients, if you were medics before, a patient comes in and they have swelling, typically it's going to be their legs from a number of issues. You can actually press on that tissue, and when you hold down pressure and you lift that finger up, it's going to leave this kind of indentation, this mark. And based off how long it stays, how deep it is, you can grade it. Now, I'm not going to ask you, tell me what grade 3, how many millimeters deep is that. Just understand, like, if you get a scenario with a patient who has pitting edema, well, that means they have swelling. It doesn't tell you why they have swelling. It doesn't tell you what's causing that, but it just tells you that there's some swelling going on in the body. Cool. All right, so let's just go through congestive heart failure. So I know we haven't talked about congestive heart failure before, and we're going to get into it a little bit when we get into the next block, block 2, when we talk about cardiac stuff. But essentially, congestive heart failure can be caused by a number of things. There's a lot of reasons why people can develop congestive heart failure. Mainly what's happening here is that the heart's not pumping efficiently. It's not pumping like it should. It's not pushing that blood out like it should. So when that happens, the kidneys, so you still have the same amount of blood in your body, you still have the same amount of fluid, but when we're not pushing out blood like we're supposed to, the kidneys don't know that. The kidneys are like, hey, I'm not getting the amount of blood that I normally get. Something's going on. I must be losing fluid. I must be hypotensive. So what the kidneys are going to do is it's going to activate this thing called the renin-angiotensin-aldosterone system. And pharmacology is going to get deep into this system, right? But it does a lot of things. It does a lot of things. But one of the things it does is that it helps our body hold on to water through sodium, by holding on to sodium. So now we're holding on to all this fluid. Our kidneys are like, hey, let's save our water. We're not getting perfused. Let's try to bump up that blood pressure. That way we can get perfused like we need to. But it doesn't know that you already have enough fluid. So now you're holding on to more water. And what that's going to do is it's going to increase that pressure in our blood vessels. Not only is it going to do that, but it's also going to cause more fluid to come to the right side of the heart, which is going to try to get through the lungs, and then go to the left side of the heart, which is going to try to push it out to the body. But now the heart's already not pumping like it's supposed to. It's not pushing out because it's weak, it's damaged. It's not pushing out that blood volume like it's supposed to. And then you just increase that blood pressure. You increase the pressure in that blood. So now the left side of the heart's trying to pump against this increased force. And it's not going to be able to do that. So you got more blood coming in, you got less blood coming out, and it's going to start to back up. It's going to start to back up into our lungs, right? And in our lungs, we have vessels, we have a pulmonary artery, pulmonary vein, we have capillaries there. When we increase that pressure in our lungs, in those capillaries, it's going to go somewhere. It's going to go out to our lung tissue. And that's how our patients are going to have this pulmonary edema. It's because there's so much pressure in the capillaries of our lungs that it has nowhere else to go, and it's going to start coming out. It's going to start going into our alveoli. It's going to start going into our lung tissue, and that's how our patient's going to have this pulmonary edema. Cool? Make sense? All right. So just a little summary, a table. Hopefully, will help you guys kind of put everything together. Again, when we talk about the location, we're either talking about edema or effusion, right? So if it's in the tissue, typically edema. If it's outside the body cavity, then we're talking about effusion. If it's based off the characteristics, if it's transudative, any number of those reasons why edema happens can cause that. If it's exudative, it has to have an increased permeability. Typically, this is due to infectious processes or some type of inflammatory process. So, CHF, right? CHF, I just talked about it. What type of, if you were to get a sample in CHF, fluid in CHF, what type of fluid do you think it would be? Would it be transudative or exudative? Transudative, yep. Tuberculosis, an infectious process. What do you think that's going to look like as you get fluid based off that? Exudative. Good job. All right, so thrombosis, so blood clots. So has anybody ever seen a patient with like a DVT or PE? Yeah? Yeah, so, if you ever have a patient come in, and I'll explain this in a second. If you ever have a patient who comes in and you think they have a DVT or a PE, hope to God that you're somewhere where you can get that patient cared quickly. I've had patients come in where I thought it was that, right? But most of the clinics that I've worked at, they've been really small clinics. I worked at one, big MTF before, but if you, especially PE, if you think somebody has PE, you gotta get them to a higher level of care. That way they can start treatment for that. Because PEs are deadly. DVTs can potentially be deadly if you don't treat it in time. So hopefully you never actually see one, but for those of you who have, I think it's good, right? Because now you know kind of what it looks like and what to expect. But sometimes the patients come in and they can be very vague. You're like, man, is this DVT or is this just somebody who strained a calf? It can be very vague sometimes. Anyways, so with blood clots, right? So our blood is supposed to clot. We want it to clot. If we have some type of damage to our vessels, we want our blood to clot, because if it doesn't, then we're going to bleed out. So it's supposed to happen. It's a good thing. Now, normally in our body, we have mechanisms in place to reduce clotting when it should not happen. We have these anticoagulant kind of properties that kind of counteract the coagulative properties. That way there's a balance. And if there's any shift in that, then sometimes we can break out in these blood clots when they shouldn't form. So, let's see. So when that becomes unbalanced, so when we talk about blood clots, what we're worried about is that we have a blood clot in a blood vessel that's not damaged, right? That doesn't have a leak in it. And so DVT is one of those examples. So blood clot in the lower vein, in the veins of our legs. Typically, it's going to be in our calf or sometimes our kind of our pelvic region. But when this happens, right? So there's three things that can cause this. You don't need all three things. You just need one of them to kick off this coagulative process. If you have injury to the endothelium, so the inner lining of our blood vessel, that endothelium actually has clotting factor. It has clotting factor 3. And that if it becomes damaged, it's going to start pushing that thing out. And it's going to kick off that coagulation cascade and start causing these blood clots. Now, you can have damage to the endothelium without actually puncturing it, right? So if you get some type of significant trauma, if you get some type of injury like something hits it pretty hard, and that can damage the endothelium. If you're a smoker, if somebody smokes and you're taking all these toxins, those toxins are going to damage that endothelium. And so that's why smoking is a big risk factor for developing blood clots. So anything that damages that inner lining of the endothelium can actually increase that risk of having a blood clot form when it shouldn't. So venous stasis. So if you have slowing of normal blood flow, if you're not moving that blood, what happens there is that those coagulation factors that we normally make, they start kind of piling up. They're starting to come in, right? And those anticoagulative properties, they're not coming in. So now we got this kind of buildup of clotting factors. And sometimes if they're touching or if they're around that endothelium for too long, that can actually kick off the coagulation cascade and cause these blood clots. So that's why you've heard when you're taking a long plane ride, you got to get up and walk around, right? Because if we're not moving our blood flow, if we're not moving that blood, then those clotting factors can build up and start potentially increase that risk of blood clots. And our blood vessels, again, typically it's going to be in the lower extremities because those lower extremity vessels, they require our muscles to contract to actually push that blood out. They're within our muscles. And so if we're not contracting our muscles, it's not pushing that blood out. So that's how that venous stasis arises with especially in the lower extremities. And then the hypercoagulable states. So I told you guys, I think on the cancer lecture, that sometimes cancer can increase that risk of blood clots because those cancer cells can actually induce these factors that can contribute to clotting, right? So cancer is one of those big ones. Pregnancy can also do it too. So can birth control pills, potentially. Because pregnancy, you're going to have lots of estrogen being produced to help you along as you're carrying that baby. Estrogen as well, right? So, or estrogen pills as well. So when you take in extra estrogen, or if you are pregnant and you're making lots of estrogen, that can actually increase your coagulation factors, increase the number of that. And so there's an increased risk of developing blood clots in those cases. Now, most of the time, we prescribe birth control, it's normal, right? But when you're taking that history of your patient, you're talking to them, you gotta ask them, like, have you had any blood clots? Do you smoke? If they have blood clots in the past or they smoke, then they can't take estrogen-containing birth control. And you'll learn about that when we get into pharmacology, but we wanna make sure we're screening our patients just so we don't potentially induce some type of blood clot in a patient who may be susceptible. But again, any one of these can kick off. You don't need all three, you just need one. If you have one, then potentially you can develop that blood clot. All right, so DVTs, so like I said, they typically begin in the lower extremities, the legs, the pelvis, and risk factors, like I said, if you're inactive or immobile, that blood's gonna hang around, it's not getting pushed out of the blood vessels, and so you're at increased risk of having a blood clot. Post-surgically, right, so people who have surgery, maybe on the lower extremity, and they're not supposed to walk around, that's a big risk factor. So oftentimes what they'll do is they'll put these little kind of squeezers on their calf, I forget what they're actually called. But what that's gonna do is actually squeeze that calf to help push that blood. Because the patient can't walk around, they can't move, and so we wanna try to get that blood going. Smokers, I talked about that, right? So you're smoking, you're taking all these toxins, it's gonna damage that endothelium and put you at increased risk for having some type of blood clot kickoff. Pregnancy, so especially after delivery, why is that the case, right? So, after delivery, most of the time, the woman's hanging out with the baby, she's feeding the baby, maybe she had some type of injury while she was having the baby, right? Maybe some type of tearing, so she's not getting up and moving around. And she already has all these coagulation factors that are produced throughout pregnancy, so you add that on top of the immobility, and there's a potential increased risk for blood clots developing after a woman delivers a baby. Cancer, we talked about that already. So cancer, again, if you have somebody who doesn't have any risk factors, they come in and they have this blood clot and you can't figure out why, think cancer, okay? But typically, whenever you see somebody with DVT, this is textbook right here. It doesn't always present this way. I'm not sure the ones who actually saw DVT, if they look exactly like this. But if it does, well, hopefully you are able to recognize that because this is textbook right here. But anyways, so we got some type of blood clot, right? We're not getting that venous outflow. It's going to increase that pressure. That fluid's going to actually start going into the interstitial space because we're not getting that outflow anymore. And so we're going to have that unilateral extremity swelling. It's going to be painful, and typically it's a deep pain because those blood vessels, as blood can't get out, it starts to distend. You have pain receptors on your blood vessels. So as you stretch out those blood vessels, you're going to stretch out those pain receptors, and that's going to cause pain. So patients are going to come in, they're going to feel like, hey, I got this deep pain. It doesn't feel like it's just at the top of my calf. It feels really deep. Warmth, so if we're not letting that blood flow out, it's going to engorge those blood vessels. We're having more blood in there. Blood is warm, right? So that extremity is going to be warm if you compare it to the other side. And then the color. So if we're engorging those blood vessels, right, it's going to start changing color. It's going to be more erythematous. It's going to be a lot redder. So these are the classic symptoms of a patient who has a DVT. But sometimes, and this is just for your FYI, sometimes patients come in and they're barely having the DVT. Maybe they just have pain. They don't have all these symptoms. That's where it can be a little bit tricky to try to actually diagnose this because it may not look textbook, but when you get out there, you'll see, and then hopefully you'll think about it back here. All right, let's take a 10-minute break. Ron says,
Yeah, they're on a different. They're probably on a different. I don't think we should do the ones different sides of the phone. Like at least you have one on each corner. So put one on this side, probably sharing it with them. I'm talking about the front. Yeah, I was thinking like that. Like that's what I'm talking about. I remember there was one I didn't go to the HEB, but I was going to CVS next door because I was one of the first guys to have me weigh my mother or something like show my niece. And that HEB like it was like extremely run down. Like it was sketchy. It didn't even look like it was just like really bizarre. It's a long inside.
I drove 20 minutes.
To buy your thoughts. Here you go. Just reheat it. You're fire in bed. I'm not taking any with me.
Oh, you did?
Get the blanket and the dagger.
I know, I'm like running the morning
What's the difference? Okay. Oh, that's nice, I guess.
Tina Turner is more my age. Thank you. Tina Turner's not a little lady. It was a female.
Well, if you look at the notes, you go back.
All the notes of this.
And you go.
Oh, wait,
Hey, did you know they just-
she's like, it's on the page. Where Aslan, like the witch trying to sell Aslan, he's like,
Did they only do one line?
no, they did like, well, I mean, book-wise, it was like 5 of them. The movie, I think it was just 3. There's 7. There's a 7 really?
Yeah, how far did it?
I know. Yeah.
Trying
You were
to
there.
school
You were
me.
there.
Yeah, with me.
I think it makes. I was also now a bigger reader.
They're really good reads, honestly. So they made this. They have some older versions of the other books, like Silver Chair, and it might be a good one. In addition to that, they're like 70s.
So like we just start making this. Damn, the airport ship. Now the stuff
It's not reading.
I'm studying more.
I'm studying.
Yeah. There's no way around.
I'm studying.
We're working on it, sir.
But they haven't been before. That would make that good ball.
Let me know what it was.
So the first way. But it doesn't matter. You still have to come
Alright guys, let's get back up. We're kind of halfway there, a little bit more than halfway. Alright, so we're talking about blood clots running, how they can form up. Now when we have blood clots, the thing we care about, so yeah, blood clots aren't good, especially if they're in the lower extremities. If we have an ET, not good, right? But the thing we care about the most is that blood clot, is that mass going to break off from where it started and go elsewhere. And so then that leads me into embolism, right? That's what embolism is. It's some type of mass. It could be a blood clot, it could be other things that starts somewhere or is somewhere and then goes to somewhere else that's not good. So for example, thromboemboli. That's what when we think about EVTs and we think about pulmonary embolisms, where blood clot gets lodged in the actual blood vessels of the lung. That's what typically happens. We got this blood clot that forms. It forms in our legs. So with a DVT, either all of it breaks off or some of it breaks off, and it travels. And it travels and travels and it travels until it can't travel anymore. It typically gets stuck, right? And if it gets into our lungs, very bad, very not good. And we'll talk about these here in a second. But it doesn't have to be just blood clots. It can be other things too. So if you have a fracture, if you break a bone, especially in the lower extremities, in the pelvis, you got fat in there, you got bone marrow. If that gets into your bloodstream, that can also break off. Cause a lot of issues if it gets trapped. Cholesterol, right? So people who have atherosclerosis, they have plaque in their arteries. Sometimes those plaques can break off. And if it's in the artery, it can go into our brain and cause a stroke, right? Sometimes liquid, so especially if you are, if you're delivering and there's some type of traumatic delivery and amniotic fluid somehow gets into the mother's blood system, that can cause a lot of issues. Now, this is just for your FYI. It's not necessarily that the liquid itself is causing the issue because our blood is liquid, right? But with this case, what happens is in the amniotic fluid, you also have other stuff, right? You got fetal cells, you got fetal blood. So sometimes what can actually happen with this is that the mom's immune system says, hey, I got all this foreign stuff in here. This ain't supposed to be here. Let's kick off the inflammatory reaction, and that's what causes the issue, typically, especially with this amniotic fluid. Now, it's very rare. It doesn't happen too often. That's the main thing. That's the main problem with that. Yep.
So it's just like a different densities depending on what the liquid is served.
For amniotic fluid?
Well, not amniotic fluid specifically, but talking about like fluid from industrial.
Yeah, exactly.
It's just like it's density issue at that point.
Yeah, so imagine like if you, did anybody work in like hydraulics or anything like that, some type of chemical thing? Yeah. So sometimes you're dealing with this big pressure system, right? And there's fluid potentially in there. And if that fluid is oil or some type of chemical, and it doesn't match the viscosity of our blood, well then if that gets into our blood system, say it's more gel-like, and it gets into our blood, then that's where you can start having those issues. Because those pressure systems, they're pretty high. I'm not sure if you've ever seen, sometimes they can cut like stone with this high thing, it's high pressure of water. If that touches your skin, well, you might lose an arm, but you're probably going to get some stuff in your blood as well. So, but yeah, exactly. It just depends on the viscosity of that liquid that's going in there. The gaseous emboli. So, for those of you who are medics, you know not to transfuse large bubbles. Small bubbles are okay. Small bubbles are fine. I don't want any bubbles though, so if you ever give me an IV, please make sure you check. But small bubbles are typically fine. Large bubbles can actually block. It gets caught in our vasculature and our small capillaries and cause issues. Deep sea divers, right? You've heard of the bends. If you come up too quickly, we have nitrogen in our blood, and sometimes that can precipitate and cause these bubbles as well. So that's why we have divers come up real slowly to prevent that from happening. So a lot of things can cause an embolism. But pulmonary embolism, this is a thing that you don't want for yourself or a patient. And it's in here, it says notorious post-op killer. So think about when you have surgery, right? And they're cutting on you, and you're making all these, your body's trying to heal, it's making all these clots because you were cut on to break. Sometimes those clots can break off and kill people. Now, and you cause pulmonary embolism, which can lead to death potentially. Now, the thing we worry about the most, though, especially after surgery, is a blood clot forming in our legs, because we're not moving, we're not contracting those muscles to get that blood flowing. And so if you have a surgery and you're not able to get up and go, well then that's what's going to increase, venous stasis is going to increase your risk of developing those blood clots in your lower extremities. Like I said, most of the time when we have a patient who has a type of surgery where they're not going to be mobile, we're going to give them those, what do they call it? Squeezers? What are they called? SCDs? Yeah, that thing. So they're going to go around your calf, and they want to compress that calf in order to get that blood flowing, okay? Now, you can develop blood clots, right? And if they break off and they go to the lungs, it depends on the amount of blood clot that actually gets there, right? And what I mean by that is sometimes these blood clots can be small, and they can go to a certain part of the lung, the very distal end of the lung, and only impact a segment of the lung. And that's still not good, but sometimes they're so small that the patient may be asymptomatic until it starts building up. Now what you worry about is this saddle emboli. So this is a large blood clot, and when it gets into the bloodstream, and it goes into the right side of the heart, and then goes to our bifurcation in our pulmonary artery, it can get stuck there. And when it gets stuck there, you got this big clot that's not letting blood flow through, right? So if that happens, our patients are gonna have immediate shortness of breath. They're gonna feel like they can't breathe because they are not getting oxygen to those red blood cells because that blood is blocked. It's not going to the lungs anymore, so it's not getting oxygenated. They're gonna have severe or sudden chest pain, and that's because we call that pleuritic chest pain, and maybe some of you have maybe felt it before, where you take that deep breath in, you get that sharp pain, and then it goes away after a few minutes. For these people, they're gonna have this persistent pleuritic chest pain. Every time they breathe in, it's gonna be very painful, and that's because they're not getting blood flow to that tissue. It's starting to affect their pleura. The pleura is not relaxing, or maybe it's dying. So when they take that breath in, it's gonna be very painful. So they're gonna get this sharp pain. Then hemoptysis, so if we're not letting blood flow through, things start dying, right? And as cells start dying, they start releasing their inflammatory molecules, they start bleeding in their chest, they start coughing up blood, so that's what hemoptysis is, just bloody sputum, bloody cough. Yep.
Was that one line, don't you typically get that line of demarcation as well?
Say it again?
Don't you normally get the line of demarcation?
For what?
Whenever a nipple line, you'll have sinus nipple line up and maybe normal, or normal color, nipple line down.
Invisibly? Not that I'm aware of.
Everyone I've seen, they've had like a super skinny line of demarcation.
Yeah.
That's right, the chest, right where the top of the ribs are.
Okay.
Up, and like super cyanotic, and really was.
Yeah, I haven't heard that or seen that, but I'll look into that. Has anybody else seen that? No? Yeah, I'll look into it. But yeah, I never heard of that or seen that. It's not, if you have a patient or if you have a test question on the pens, they don't typically talk about that.
Okay.
But I'm interested and I'll look into that. All right, so that's more the venous side, right? So you get a blood clot in the venous side, that's typically what can happen. Now, if you get a blood clot in the arterial side, so the opposite side, right? What happens here is that blood clot can actually go to other places, for example, our brain, because that our arterial blood goes to our brain, because the venous blood goes to our heart, our liver, our lungs, right? The arterial side is going to push blood to our brain. If we have a clot in our arterial side, and if it goes into our brain, it can cause an ischemic stroke. So we're not getting blood past a certain point, that blood's not going to the brain cells, the brain cells are going to start starving and then eventually die. Now, normally this happens, so atrial fibrillation. Atrial fibrillation, they'll talk about it more in cardiology, but essentially what's happening there is that the top part of the heart is not contracting like it should. It's just kind of quivering. So the blood in there, you're still getting blood flow because that ventricle is still going to relax and let that blood kind of come through. But as it's sitting up there, it's not really moving. It's not, I mean, it's, the top part of the heart's quivering, it's doing some type of turbulent thing, but it's slow in there. And so what I say, if you have stasis, if you don't have blood movement, you're going to start to collect these large amounts of coagulation factors, potentially kick off that blood clot that's going to then go into that ventricle and then go elsewhere. And the artery system, that's a fast system, right? It's not like our venous system where it's a little bit slower. That thing is fast. And so sometimes what can happen is that can actually not go up, right? It can go elsewhere, it can go down, but sometimes it can go all the way down to your toe. So you get this thing called blue toe necrosis. So it's a small blood clot that skips the arteries that lead up to the brain, and they go down to the arteries of our foot. And so you get this necrotic tissue because you don't have blood flow past that point. So I'd rather have a blue toe necrosis than an actual ischemic stroke. But sometimes that can cause that issue. And again, when you think about all the things that can happen, I'll take that over an ischemic stroke. All right, hemorrhage. So there's a lot of terminology with hemorrhage, and all hemorrhage means is that you're bleeding. So when we think about hemorrhage, we normally think like we're losing large amounts of blood, and that's true. We use that term quite a bit. But all hemorrhage means is that you're bleeding. That's what that means. And a lot of the words that involve bleeding either have hemo or hema associated with it. So hemothorax, you got blood in that pleural cavity of the lung. Hematuria, you're peeing blood, right? Now, there's a few words here: hemoptysis, hematoemesis, and epistaxis. And it says patients easily get this confused. The reason why that's in there is because sometimes a patient will come to you and they'll say, hey, I am vomiting blood. And you're like, really, right? That's not typical. And so then you go and you get the history, and you get that history and you ask the patient, well, what was going on before that? And they say, oh, I had a nosebleed. So if they have a nosebleed, epistaxis, what do patients do when they have nosebleeds? They swallow, right? They go like this because they don't want it dripping out of their noses, so they go up and they swallow it, and then it irritates the lining of the stomach, and so maybe they do throw up, but they're throwing up not blood from their stomach, blood from the nose. And so that's why some patients get that confused, or maybe it goes into their airway and they cough it up, and so now they think they're coughing up blood. Now patients definitely can have hemoptysis and hematoemesis for sure, but if you ever have a patient who had epistaxis first, maybe consider that as probable cause versus something more serious. And then we got hematochezia. Now what's the difference between hematochezia and melanoma? Yeah, so hematochezia is going to be bright red, melanoma is going to be black, right? You're going to have black stool. And the difference between that, right, so with hematochezia, typically you have bleeding where? Upper or lower GI? Lower, right? And the melanoma is typically going to indicate you have bleeding where? Upper. Because that blood is being processed, and by the time that you actually get rid of it, it's going to cause your stool to be black. So that's that difference. So when you ask a patient, have you had blood in your stool? You got to ask them too, have you had black blood? Or have you had black stool? Because maybe they're not correlating that black stool as actual blood, right? I've had this happen where I had a dude come in, and he was anemic, and I'm like, have you been bleeding? Have you had blood in your stool? He goes, no. I was like, have your stools been black? He goes, oh yeah, they've been black. I think he had a peptic ulcer for that guy. But, so yeah, make sure you don't just ask your patient, have they had blood in their stool? Make sure you get the characteristic. Is it bright red? Is it seen black stools? Because then that will give you more information. We sometimes get confused and we just ask if they just have blood in the stool. The patient doesn't know that. The patient may not know that black stool is not good. All right, some gross pictures here, but so hematochezia, again, it's that bright red blood that you're going to see. Epistaxis, we've all had nosebleeds before. Hematoemesis, now this dude has a bunch of blood around his mouth. Maybe he's coughing up blood, right? But if you look at his eyes, they're jaundiced. If you look at his skin, it's jaundiced, it's yellow. And so maybe, most likely with this guy, he has a type of liver disease. And you'll learn, we'll talk about this when we get to GI, but sometimes people who have liver disease, especially cirrhosis, they can develop esophageal varices, these kind of outpouching veins in their esophagus. And if they rupture, then this patient's going to start throwing up, and they're going to start throwing up large amounts of blood. Hematuria, so that's blood in the urine, right? You're going to see that quite a bit in your patients who come in for like UTIs, or if they have kidney stones. All right, so bleeding. So sometimes we can have bleeding, and it could be at the surface or subsurface. And we use different words for this. So petechia, all that means is that you have pinpoint red dots under your skin. And most of the time, that's due to some type of increased pressure in the capillaries. So if you're vomiting, if you vomit, you're going to increase that pressure in capillaries, and so sometimes those capillaries can burst, and as a result, you get these kind of pinpoint red marks on your skin. Or if you're coughing very hard, sometimes that can happen. Purpura is essentially the same thing. It's capillaries that have bled, but there's a greater amount of them. Now, most of the time with this, it's going to be some type of inflammatory process, so some type of vasculitis, type of issue with the vessels themselves that are causing them to dilate, and so you get this large amount of blood kind of pouring out of the capillaries and causing this greater kind of purplish marks on the skin. Sometimes it can be due to platelet disorders as well. If you have some type of platelet abnormality where they're not clotting, well, then that can sometimes cause purpura. But all purpura is just an increased amount of subsurface bleeding from capillaries that are not holding in the blood. With ecchymosis or a bruise, we've all had this. We got some trauma to our skin, didn't break the skin, but it damaged the blood vessels, and so now that blood vessel is bleeding on your skin. But most of the time, it's going to heal without issue. Now, sometimes patients will come in and they'll say, "Hey, I have a rash." And sometimes it's going to be hard to determine, is it really a rash or is it actual petechia, purpura? Well, probably not purpura, maybe sometimes. And so one thing you can do is that you can do this dioscopy. So you get a glass slide and you can push on that lesion. You can push on that red mark. And if it goes away, it's probably your rash because you're going to compress those blood vessels, you're going to stop that blood flow, and you're going to get this blanching, this whitening of the skin. Because blood's not flowing through there. But as soon as you let go, that blood's going to come back. And you can see it better if you actually put like a clear glass slide on it versus your finger. Now you can do your finger as well, and just gotta look really quickly. But if it doesn't go away, if you push on it and that red mark still stays, then that tells you that there's some type of bleeding going on. Cool. All right, shock. Different kinds of shock. But all shock is all that means is that we're not perfusing our organs or our tissues correctly. And if we're not doing that, what did I tell you? If we're not getting oxygen to those tissues, to those cells, they're going to start becoming hypoxic. And they're going to start becoming ischemic. And then they're eventually going to start dying, right? But there's a number of things that can cause shock. And there's different names for shock, right? We're going to use the most common names, but when you get out there, and they're in here, like the different names are in here as well, you may see other names for a particular type of shock that, because it changes. Like if you read different books, you're going to see that sometimes they'll call hypotonic shock, distributive shock. It's the same thing, okay? But really focus on, what I have in the red there. That's what I'm going to, if I'm going to use, for that, I know. I'm not going to use the extra name if I use it. Okay? All right, so hypovolemic shock. So that makes sense. If we're losing blood, if we're losing fluid, we don't have volume in our blood system, then we're not going to have that fluid that we need to actually push that blood forward. And so that's what we call hypovolemic shock. When we lose a certain amount of fluid or blood, you can see that in patients who have gastroenteritis and they're throwing up or they're vomiting. That's what we worry about, especially when they're not able to hold down fluids. We don't want them to develop hypovolemic shock. We have cardiogenic shock. So all this relates to is just that the heart's not working well. Something's going on with the heart that's not pushing that blood flow. Now, other things can cause the heart not to work well, and I'll show you what I mean here in a second. But all that means is that the heart's not pushing blood like it's supposed to. And then we got hypotonic shock, also called distributive shock. Okay? And what happens here is that for some reason our blood vessels dilate, and because they're dilated, now we don't have that force, we don't have that tonic kind of pressure that we need to actually push that blood forward because they're too dilated. So you go from a vessel like this to a vessel like this. Well, now you're decreasing that pressure. When we decrease that pressure, we're going to decrease that pressure to elsewhere and cause issues there. All right, so hypovolemic shock, we talked about that. So hemorrhage, obviously, if you're losing lots of blood, you're going to go into shock because you don't have that volume anymore. Water loss, so I talked about dehydration. So when your patients come in, you got to make sure that they're able to hydrate. That's like the main thing. We don't really care if they can eat great. We want to make sure that they're taking in those fluids, because if they're not taking in fluids, if they're throwing up, if they're having lots of diarrhea, well then they're going to become hypovolemic, and potentially that's going to lead to shock. Burns can also do it. So our skin helps keep in our fluid, right? If we have a large area of burn on our body, we don't have that protective mechanism in place anymore to keep that fluid there, so it can actually evaporate from our body. So with burns, you also worry about hypovolemic shock as well. Cardiogenic shock, so heart attack, right? That makes sense. If you have a heart attack, myocardial infarction, you damage that heart, it's not going to pump efficiently anymore. Well, then it's going to lead to cardiogenic shock because we're not pushing out blood to our body. Ventricular fibrillation, what that is just the bottom part, the ventricle of the heart. It's kind of doing what I talked about with atrial fibrillation, where it's just kind of shaking. It's not actually contracting. When it's not contracting correctly, you're not pushing out blood. Now, normally, ventricular fibrillation is going to be from a myocardial infarction. That's the kind of progression of that. If you don't catch it in time. But again, if you're not pushing out blood flow, well, then you're not going to be perfusing those tissues and cells that you need. And then pericardial tamponade. So that's where we have some type of bleeding within that pericardial space. Typically, from some type of trauma, maybe some type of impact to the chest, maybe a car crash, and so we have bleeding in that pericardial space. And as that blood fills up, I'll show you here in a second, as that blood fills up, in that space, it's going to impact the way the heart can actually relax and take in blood, which is going to decrease the amount you're able to push out. And then tension pneumothorax, that's a subtype of just a pneumothorax. So tension pneumothorax is a little bit different. So pneumothorax, you have some type of air in the chest cavity, right? With the tension pneumothorax, you're starting to get this increased amount of pressure in your thoracic cavity, and as that pressure increases, it's going to start pushing on the heart, it's going to start pushing on that vena cava, which is going to impact the amount of blood that's coming through. And we subtype these as obstructive shock. So they're still cardiogenic shock, but because we have some type of obstruction, whether it's the blood in the heart or the air in the thoracic cavity, it's a subclass and it's called obstructive shock, but still cardiogenic shock. So again, pericardial tamponade. So you have some type of trauma, you start having blood fill up into that pericardial space, and that blood's going to start pushing out into the heart. But think about anatomy, right? The right side of the heart has a lot thinner wall than the left side of the heart. When that blood is pushing into the right side of the heart, it's going to start decreasing that space in that right ventricle and in that right atria. So when blood's trying to come through, you're not having a lot of blood getting through. And as a result, on the back end, when your heart's trying to pump out blood, you don't have a lot of blood going out. So that's what's going to cause shock in our patients here. And remember Beck's triad. Remember Beck's triad because every class I've taken, they've asked about something about Beck's triad. Or when you get to phase 2, they're going to pimp you. You guys heard of pimping before, right? Yeah. Pimping is where you got somebody, a specialist, who's just asking you a bunch of questions, trying to see if you don't know yourself, right? So they like to ask, especially surgery for some reason, they like to ask about Beck's triad. So make sure you know that. And again, it makes sense. If you have some type of cardiac tamponade, pericardial tamponade, you're going to have low blood pressure because you're not pushing out blood, right? If you have fluid around the heart, especially blood, when you go and listen to that heart, there's going to be something in the way. There's going to be something in the way that's going to sound muffled. So you have fluid there, you listen to the heart, it's not going to sound like a normal heartbeat. It's going to sound like there's something kind of in the way to actually transmit that sound. And then JVD, so JVD is where you get that increased pressure in your jugular vein, right? So if we're not pushing blood, if we're not getting enough blood to the right side of the heart, that starts to back up. And when it backs up, it goes into our jugular. So when we lay our patients down 35, 45 degrees, we can see that pulsation every time the heart tries to beat. And then based off the level of JVD kind of is the severity of the issue, right? So that's Beck's triad. So hypotension, muffled heart sounds, and JVD. Now we treat this with what's called a pericardiocentesis, where we're actually get an ultrasound, definitely want to do some ultrasound guidance, stick a needle in that pericardial sac, and you try to draw out that blood. Now hopefully, whatever caused that bleeding clots and stops, but sometimes you have to do it multiple times. Sometimes you have to be more invasive, but in an emergency situation, we're just trying to get that blood off quickly so that heart can start filling back up and start pushing out blood. With tension pneumothorax, again, so we have some type of trauma into our chest. It penetrates our chest wall. Now, what typically happens is that it's not going to create this nice clean hole, right? Typically, if you have some type of penetrating trauma, some type of, you get stabbed or whatever, you get shot, you're going to have a flap of tissue. It's going to close off. And when you breathe in, it's going to create negative pressure. So it's going to draw that air from the outside into our pleural space. And when you breathe out, that flap's going to close, and so you can't push that air that you just brought in out. And every time you breathe in, you're creating more, you're adding more air into that space. So every time you breathe in, that pressure's getting bigger and bigger and bigger. And eventually what can happen is that, like I said, it can compress the heart, it can compress the vena cava and cause blockage of that blood actually coming back into the right side of the heart. Now, if it lasts for a long time, if you're not able to fix this quickly, then what it can actually do is cause tracheal deviation, where you can physically see that trachea is being pushed from all that pressure inside the thoracic cavity. So patients with this, they're going to have trouble breathing because they're not getting enough air into that affected side of the lung. So they're going to feel short of breath. They're going to start trying to breathe quickly to try to get oxygen into the good lung. When you go into their lung sounds, they're not going to have any because, or they may have diminished breath sounds because, again, that space is filling up with air. The lung's not filling up with air. That space is. So when you compare the two sides, one side's going to sound nice and you're going to be able to hear the breath moving. The other side's going to be silent or very diminished. You're going to get JVD, and we talked about that, right? We're compressing that vena cava. We're not letting blood go to the right side of the heart. It's going to start backing up and causing that JVD. And then, like I said, that tracheal deviation, that's particularly a late finding. That's where they have so much pressure that it actually starts pushing on that trachea. And that's typically a very bad sign. All right, so things that can cause JVD. So heart failure can do it. We kind of talked about that a little bit. how the heart's not pumping effectively, so that can cause that backup and cause JVD. We talked about tamponade pneumothorax. So superior vena cava syndrome, that's one of these rare things where you have some type of blockage near your vena cava, it's the superior one, right? Typically, it's going to happen. It can be due to a lot of things, but most of the time, if somebody has what's called a Pancoast tumor or a type of tumor in their lung, the apex of the lung, that can actually grow and start to compress that vena cava, and so as a result, your patient may have JVD with that. That's more of a rare thing, but these other ones for sure, especially with CHF, definitely you're going to see JVD with this if it's not treated correctly. But that superior vena cava thing, that's a little more of a rare thing. All right, so hypotonic shock. So hypotonic, so all that means is that our blood vessels have decreased their tone. Like I said, they go from this to this, and when we do this, we're decreasing that pressure within that blood vessel. And when that happens, typically it's going to be in our periphery, so our blood's going to pull in our periphery, and it's not going to go to our core, not going to go to our heart where it needs to be to actually be pushed out. Now, three things can cause this, right? Septic shock, anaphylactic shock, and neurogenic shock. With septic shock, there are certain bacteria that have these toxins within them. And when our body starts to fight off these bacteria, or when we start to treat these bacteria with antibiotics, and we start killing these bacteria, they release these toxins, and those toxins actually kick off this large inflammatory process in our body. So as a result, remember inflammation, right? It's going to cause that permeability, it's going to cause the vessels to dilate. We're going to get this kind of widespread vasodilation within our body, and so that can lead to, that's what septic shock, when people have septic shock, that's what typically causes these bad outcomes. Because these bacteria have these toxins, and when they start dying, your body's going to say, okay, it's time to kick off this inflammatory process. Anaphylactic shock, we talked about that already, how IgE, how those mast cells get involved, and when the mast cells get triggered by the IgE and that antigen, it's going to kick off that histamine release, so that's also going to cause that hypotonic or that vasodilation. And then neurogenic shock, so with this one, we have some type of trauma, some type of injury to our brain or our spinal cord. And our brain and our spinal cord, that controls our sympathetic system, right? So if we take that out, we lose, and the sympathetic system is important in keeping that vascular tone. If we take that out, then those blood vessels are going to dilate. And when they dilate, again, it's going to cause that decreased blood back to the heart and cause that shock in our patients. So this is one of those, somebody has some type of fall or some type of injury to the neck, this is what we worry about with those guys. So stages of shock. So initially when somebody's going through shock, right, our body has a way of trying to compensate for it. And when it happens, so we have these receptors in our body that kind of, these baroreceptors that help our brain determine, do we have the right amount of pressure? When it starts to sense that we don't have the right amount of pressure, it's going to kick off mechanisms to help try to bring that pressure back up. So we're going to get a release of epinephrine, norepinephrine, right? That's going to cause our heart to start beating faster to try to increase that blood flow. It's going to cause our periphery to start vasoconstricting to get that blood flow from the periphery where we don't really need it back to our internal organs and our aorta to try to get that blood flow going. So when patients are initially going through this compensatory mechanism, they're going to feel cold, they're going to feel thin because we got that vasoconstriction in our skin. They're going to feel like, okay, I feel like I'm really cold because I don't have enough blood there. So that could be a first sign that, hey, somebody is potentially starting to go into shock. We need to step in and do something. Because if we step in, if we give them fluids, if we give them pressors, then potentially we can mitigate that irreversible shock where there's no really coming back from that. But with that, right, if we don't catch this in time, if we're not being aware of our patients and we don't see that, hey, something's going on here, then they can go into something called decompensated shock. And it's still reversible, right? But if you think about our bodies, we can only release so much epinephrine, norepinephrine. We can only release these chemicals for so long before they start to fail, before we run out of it. And so these patients are going to start having that low blood pressure because we're not having those mechanisms in place because they're starting to kind of burn out and die out. They're going to feel short of breath because they're not getting blood flow to their lungs because things aren't working, right? We're not getting that blood perfusion. Our kidneys are going to try to hold on to water, so we're not going to be peeing more. So they're going to have oliguria because the kidney says, hey, I'm not getting perfused. I need to hold on to sodium. I need to hold on to water, so they're going to stop peeing. And then if they're not getting perfusion to their brain, well, if you don't have blood flow to the brain or you have a decreased amount, you're going to start getting confused or agitated, right? you need that blood flow to actually help you think, and if you're not getting that blood flow, then our patients are gonna start kind of being out of it. And then you get into irreversible shock, and that's where, hey, we tried, we maxed out, we're no longer getting those compensatory measures kind of sent off to our body anymore. So now that's when we start getting that circulatory collapse, where we're not getting perfusion to our organs. Without that perfusion, our cells start to die. When cells start to die, our organs start to die. And when they die, there's no coming back from that essentially, right? They're dead. And so our patients, they're not getting perfused to the brain, they're gonna be out of it, they're gonna lose consciousness. And so if we have widespread cell death, if our organs start to fail, then eventually that patient's going to die. All right, so vasovagal syncope. So shock, you may see this, especially if you're working in the ER inpatient, maybe if you're deployed, something happens, right? More often, especially when you're working in a primary care setting, you're going to see vasovagal syncope. Now, maybe some of you have experienced this, maybe some of you don't like needles. Patients don't like needles sometimes, and so what happens is some type of stimulus, right? It could be a needle stick, it could be the side of blood, it could be that the patient gets scared. There's this reflex that happens in some individuals. And so what that does is that it decreases our sympathetic tone, so it causes our blood vessels to dilate, and it increases our parasympathetic tone. So it causes our heart rate to slow down. So when we have dilated blood vessels, we have a slower heart rate, we're not pushing blood anymore, we're not pushing blood effectively. And if we're not pushing blood effectively, especially to our brain, what is the brain going to do? It's going to say, okay, it's time to go to sleep. And so you're going to have syncope, you're going to pass out. Now, when that patient passes out, or when they go flat, when they go supine, they no longer have gravity kind of pulling that blood flow back because they're laying supine. So eventually, they're going to have that blood flow go back to the brain. The patient's going to wake up. They're going to know, okay, they're going to know what happened, because before you actually have that syncope, if you've ever seen somebody who's had a vasovagal response, if you look at them, they look like they're about to pass out. They start having these cold sweats, they start feeling lightheaded, they kind of start talking a little weird, and then all of a sudden they're out. But the thing with this is that once they restore that blood flow to the brain, they're going to come back within seconds. Typically they're back within seconds. They may be a little confused in the beginning, but it's going to clear very quickly, and they're going to know where they're at, they're going to know what happened. So they're not going to have what's called post-ictal symptoms. So post-ictal, that's related to seizures. If somebody has a seizure, they're going to be confused for a long time. They're not going to know where they're at potentially. So I say that because a lot of times when you're working in the primary care setting, you're going throughout your day, and then they say cold blue in the lab. Probably somebody had a vasovagal episode, and you may be the only person there that day because the doc's on vacation or you're working in a small clinic, and you're going to have to respond to that. So what are you going to do when you have that patient? When you had that patient who just passed out in the lab because they were getting their blood drawn? How do you know? How do you know that they didn't have a seizure? How do you know that this was just a vasovagal syncopal episode? So that's why you talk to your patient, you get the history. And then if they give you that story that they just passed out because they had a response, then they're probably fine. Maybe you bring them back, just do a quick evaluation, versus if they're like, they don't know where they're at, they're confused, maybe they lost their bowels on themselves, well then that's different, and you gotta get them to a higher level of care. Make sense? So that was it, guys. Any questions? Cool. I'll be up here for a little bit.